Good morning, good afternoon to all, and welcome to our webinar today. My name is Donatella Decise. I am Global Director for Patient Engagement at Sobi. I'm really delighted to have all of you with us today for our journey through a topic of great importance in ITP management, mastering shared decision-making for better outcomes in ITP. Well, we all know that ITP can have a profound impact on individuals' lives. When it comes to the objectives of this webinar, as healthcare professional, it is crucial to understand the power of shared decision-making and why it holds the key to improved outcomes and also to enhanced patient experiences, and why not compliance and responses to treatments. Shared decision-making is a collaborative process that involves everyone, including patients, healthcare providers, and even other people like caregivers or nurses working together to make informed decisions about their healthcare journey. This approach acknowledges the unique perspectives, the values, and the preferences of each single individual, fostering a partnership that really facilitates everybody's work and everybody's life in the end. Stepping into today's agenda, as you can see from that, we will dive into the reasons why shared decision-making is particularly vital in ITP. We will explore also how it can help patients navigate their journey and address their physical and emotional challenges associated with their disease and with life with their disease. We can foster together a sense of autonomy and empower these patients to ensure better satisfaction and, in the end, better outcomes. We will hear from our experts who will share their perspectives, their insights, their experiences, and their daily findings on shared decision-making. They will shed a light on best practices and on the tools and resources that we have at our disposal to facilitate this collaborative process. Our distinguished speakers today are Mervyn Morgan, who is the Chief Executive Officer of the ITP Support Association in UK. We have Dr. Nicola Cooper. She is a consultant hematologist and senior lecturer at the Imperial College in London. And we have Glynis, our guest, a person living with ITP, who collaborated with us in bringing her perspective into this webinar for all of us. So by the end of this webinar, it is my hope that we will have gained all a deeper understanding of the power and the transformative potential of shared decision-making in ITP. We will be equipped with knowledge and strategies to foster a more patient-centered care, and I would say patient-driven care. And we will be enabled to improve treatment outcomes and to promote a sense of shared responsibility among all the stakeholders participating in this process. Together, we can pave the way for a future where shared decision-making becomes a key part of the management of ITP, ensuring that every patient's voice is heard and their needs are met. I would like to thank you once again for joining us today, and let's embark together on this journey. Mervyn, the floor is now yours.
Thank you, Donatella, and thank you for inviting me to take part in this meeting. Shared decision-making in ITP. Shared decision-making. Shared decision-making is when physicians and patients work together, putting patients at the centre of decisions about their own treatment and care. The current clinical guidelines for ITP recommend that treatment decisions are based on a shared decision-making between both the physician and the patient. The ASH guidelines are highlighted on this slide were published around 2020. There was also a paper published in the British Medical Journal around 2017, which looked at a patient-centered diagnosis. You could call that one of the forerunners of shared decision-making. The NICE guidelines in the UK for shared decision making were published in 2021. In 2020, the ITP Support Association carried out its patient perception survey, which had over 200 responses. This survey was used as a foundation for the ITP Roundtable project, where haematologists, patients, and members of the ITP Support Association examine the survey's findings to identify the needs of the patient. Out of this project came the shared decision-making toolkit called Making the Right Choices in ITP Management Care. This toolkit has since been endorsed by a number of developed colleges in the UK. Then following on from the toolkit, then come the ITP discussion guide, which was developed and published. Both documents have been well received, with copies being requested by hospitals and patients alike. The key barriers affecting implementing shared decision-making of healthcare professionals. The first one is time. We are all acutely aware of the pressures on the system these days, and time is precious. Every minute is precious to the consultant in ensuring that the patient makes full use of the time available. Education, the knowledge of treatment options available is paramount, hence the shared decision-making toolkit that was published. Lack of knowledge can lead to difficulties in starting a conversation about shared decision-making. Now, I've already said resources. The resources are needed. The resources are there if you know where to look. The shared decision-making document, the ITP discussion guide, information on the ITP Support Association website. Lots of information is available for patients and clinicians alike. The importance of shared decision-making. Collaborative approach to patient care through shared decision-making. Firstly, empowers patients to express their personal goals, their lifestyle choices, and the needs and preferences to help them improve their understanding of their own personal ITP experience. And when we say lifestyle choices, the lifestyle choices of an ITP patient in their teens, 20s, 30s, or even 40s would be totally different to the lifestyle choices of someone in their 50s, 60s, and older. We also need to ensure that the patients have a good understanding of the benefits, the harms, and possible outcomes of the different options available to them. Hence, the document Shared Decision Making, Making the Right Choices in ITP Management Care is so important. We need to support the patient to shape their informed decisions about their care and treatment, but these decisions must be based on clinical evidence on what matters to them. The collaborative approach to care can have numerous benefits in clinical practice. The benefits for the physician: firstly, increased treatment adherence and patient participation. There's then the improved health behaviours from the patients, i.e. if the treatment is working and the patient has the knowledge of the options available to them, there should be less pressure on the system. And it helps to identify any gaps in care and the services required, or in some cases not required. The improved connection with patients may positively affect any liability. So we need to get that connection between the physician and the patient. And in the longer term, it will increase staff performance and, more importantly, staff morale.
Thank you very much, Mervyn, for this interesting perspective on shared decision-making in ITP. I believe you are a true expert because you produced together with the community a lot of resources and tools that facilitate this process. And I'm curious to know about the perspective of a distinct physician like Nicola Cooper, and to learn also what Glenys thinks about shared decision making. So Nikki and Glenys, the floor is yours.
Hi, I'm Dr. Nicola Cooper and I'm with Glenys Yexley. So I'm a haematologist and Glenys is one of my patients who has a diagnosis of ITP. And we're going today to talk about both of our opinions or experiences really of the diagnosis of ITP, the management, how to make decisions, how as clinicians we could make things better based on how Glenys has felt as a patient. So Glenys, thank you very much for coming today.
Thank you.
So can I take you back to when you were first diagnosed with ITP? What were your symptoms? You know, how did you feel about it? What was that time like for you?
Right, it's 10 years ago. 10 years ago,
Goodness.
long time. Yes, I just had an incident at home where my head swelled up unexpectedly. So I went to, and it was a Sunday, of course. So I got an emergency appointment with a doctor, and it took a while. He just said, "You banged your head, it's a contusion." No, I didn't bang my head. But eventually he analysed some blood from me and realised my platelets were really, really low. So I was admitted to A&E.
So did he send you straight to A&E?
Yeah.
Was that part of it quite scary?
It was really,
well?
yeah, because, you know, I got nothing with me.
Yeah.
I didn't think
Yeah.
I'd be sort of going off to hospital. Yeah, so it was. And also he said, "How do you get here?" And I said, "Public transport." And he sort of, "Get a taxi."
Yeah.
So I started to feel more anxious then, thinking. And A&E took ages. It was, very busy, and it took a long time, and everybody was puzzled as well. It's not.
Yeah.
Yeah.
And what was your platelet count then?
I think it was about 20.
Okay.
Yeah. And they gave me a transfusion of platelets. Yeah,
Okay.
almost
Interesting.
immediately.
Yeah.
Yeah, and then I was in that. I was there for about 3 days, I think, while they were just trying to work out. And I think it is with ITP. If it's not that, if it's not that, if it's not that, that's what's left.
The diagnosis of exclusion. Yeah. And how does that feel as a patient?
Perplexing, and just because you're constantly being asked lots of questions about your lifestyle, about your previous medical history, and all that sort of stuff. And I have a really bad memory for dates, so I keep a note with me of things like that. So they were really impressed.
That's one thing I do remember is you always had a notebook with you.
Yes.
I think that's one thing I think I would certainly advise patients is have a notebook, write everything down. And did it feel, I think one of the other things I think is that you can't always remember everything that someone tells you. So is it all a bit overwhelming at the beginning?
It is because not knowing the existence of platelets for a start, so that's the issue. What are they? What do they do? Sort of thing, and trying to get your head around how the immune system works.
Are a lot of new cells for you, aren't they? And I think that's something I've learned from patients as well, not knowing what ITP is, what a platelet is. So it is ITP awareness week soon. What would you think was important for people to know about that?
I think thinking back, when I tried to tell people what was wrong with me, it was really hard. You can see them glazing over after a while because I didn't have the language or the real knowledge. So I think giving people an explanation of how to say what it's about would be quite helpful early on because you're thinking about something. And it did trigger me to research, though, which is really useful to actually sort of look into all that.
And when you were researching, how easy was it to find out information about ITP?
I can't really remember now. I think if you focus on the platelets, you can get quite a bit of information, and knowing that they're the issue sort of gives you some sort of knowledge about it. But it's a while ago. There's been a fair bit of research since I was diagnosed, and I think initially there wasn't as much as there is now. So
And when you're first diagnosed with ITP, so one of the things we're trying to talk about now is shared decision making. Did you feel able to be part of shared decision making at that first diagnosis point?
I think so. the doctor I saw who actually gave me the diagnosis, I got a holiday booked the following week, and I was sort of anxious that should go ahead. It was all paid up, and it's quite a complicated holiday. It's taken a while to set up. So he's talking about a bit about what it is and what treatment I was going to have, which was steroids. So I said, can I still go on holiday? And so he said, it's up to you. It's your decision if you go or not. Bear in mind this, but it's up to you. And I think that was very wise, because if somebody had said no to me then, I'd have probably gone and been really worried. So I decided not to go. No, I can't.
So that was an important, good point, is that someone did actually say these are the considerations, but actually it's your decision. And I think that doctors can sometimes be a bit too paternalistic and say, be too scared about risks as well. I don't know if you felt that too in your interactions with doctors at different times.
I'm quite risk averse, I think, so it's probably not the right person to ask. I remember when I was in hospital on the ITP ward at one stage, there was a girl I got friendly with, and she was going to this music festival, come what may, and her count was below 10, but she was going. It's a different sort of attitude, isn't it?
And then, so you had steroids at the beginning. How did you feel on the steroids?
That was a journey. I'd not been on them before, and I was on a huge amount. I looked it up, I was on 85 grams a day to start with, and then it tapers down. So gradually you get less and less sleep, because it's a couple of hours, and then your body wakes you up and says, it's time to go, go. But there's an underlying exhaustion under it all. So you've got this weird sort of combination of huge energy and exhaustion that you're running on all the time, which is quite weird. So there's some things that you just can't really do, some of the sort of...
Do you feel like anyone explained that to you?
No. I was told I would gain weight, which was an issue for me, because I'd been managing to lose weight up until that point. And I was quite happy with how my sort of diet was going. So that was a depressing thing, because I did gain weight, and I'm still trying to lose it.
Are you still trying to lose it now? And I think that's an important point, actually, isn't it? It's not just for that period of time you're on the steroids. That lasts a long time, doesn't it?
I mean, one of the bonuses, as somebody else agreed, you got a clean house. Because that's the sort of thing you can do with all that energy, is clean and organised and sort. And
do you think, with the benefit of looking backwards, do you feel like you were on the steroids for too long?
Well, I was medically, because it damaged my adrenal glands, and I lost some bone mass as well. But there wasn't a lot of options, as I understand it, because the other things I tried, they had this pattern, which I think of as a roller coaster. So very good at first, and then down to a crash. Try something else, same thing. So, again and again. So the steroids were the only thing that I knew, or it was known, would keep the sort of...
And we went through quite a few different treatments, in fact, for you, didn't we?
Yes, we did indeed.
Did you feel like you were... What did we do well, and what did we do not? Oh, how could we have done things better from your point of view during that time?
Well, I think I was always involved in the decisions. I felt that very strongly, that where there were options, I was they were explained and I could decide. I think some of the negative symptoms of it would have been nice to sort of have a clearer picture of what to look out for that, because one of them was MFF. I got a fungal rash, and I didn't realise that was what could happen with that sort of thing. So and like with the steroids, with the bone density thing and the adrenal glands, would be nice to have got a sense of, you know,
So having more information
this is helping
about
you,
things.
but
Yeah,
you know,
yeah.
you need to bear this in mind.
Do you think that is if you have a lot of information, does that help you, or does that make you feel more
it's
scared?
always that, isn't it? Yes.
Yeah.
It's true. I don't know really. I mean, everything worked out okay with me in the end, so it's because I recovered from the sort of side effects of the steroids. I keep warning other people about them. So I don't know if I hadn't sort of recovered from that, I think I'd probably feel differently. Yeah.
And how about with the romoplastin? How did you find the injections and?
Well, that's an interesting, because that doesn't seem to have any side effects, which is really rather nice.
Yeah. I think that's not in everyone, actually, interestingly. So for some people, not many, they do get side effects.
Okay.
So and I think that's one of the things I think we've learned too. Okay. And you can get rare, you know, some people get aches and pains, and some people get headaches, and most people get nothing. So I think that what I've learned that doctors need to do is just be much more open-minded. I like you bring up the fungal infection on the skin. I'm not sure that everybody would associate that with MMF. And I think that my advice, certainly for clinicians, is to listen to your patients. And actually, if they tell you that something is associated with starting a drug, it may not be related to that, but it could be related to that. And I think that's really important. And I think the other thing is like feeling listened to. Yeah,
yes, indeed, yeah. And there's a time element to that, but there's also allowing a bit of silence. Because if the talk stops for a little while, you get a chance to as a patient, to sort of regroup and think, now what was it I was going to,
Yeah. That's interesting, because I think that's often a big problem, I think, in clinic actually as well, isn't it? Not having the time to be able to do that. And then you wrote lots of notes, I think.
Yeah, I used to prepare quite well for the appointments.
And how would you, I think you did. I just wondered what tips you might give to patients or to doctors about that. How did you prepare? How much time did you spend? How did you prepare for it? And how did that help you with your clinics?
Well, first of all, there's the symptoms I know to look out for. So making a note of if I've had any bleeding or bruising or anything like that. So I'd make a note of that. But also just thinking through the little sort of health-related incidents that I've had since the last appointment and thinking, would any of those maybe be worth speaking about? Because you never know.
Yeah,
and jotting those down. And depending where I was in the treatment, what was working, what didn't seem to be, questions to do with that. And I remember when rituximab came up, and I kept not wanting that until I had to have it. But just getting a sense of what the anxieties were about it and related to my particular biology, whether.
Yeah, that's an interesting question for me as well, actually, because you're not alone in that. A lot of people don't want to have the rituximab treatment, and I'm not entirely sure if that's us, the way we present it, or whether it's information you've read about it. How did that affect you? What led you to be anxious about that treatment?
Because I looked it up, that's what I would do. When you suggest different sort of medications I could go on, I'd look them up and sort of see what's said about them and things like that. And the first thing I saw when I looked up rituximab was danger of death. It's literally what it said when you open it. So you read through and I thought, I won't do that unless I have to. But then,
And do you remember which website that was on?
No, I don't. No. I usually try and go on NHS and sort of those sorts of, but it does depend what options you get when you first.
Sure, that's quite important actually to know then. Yes. And did you have a chance to? Did you feel like you had a chance to talk about that anxiety?
Yes, I did. I remember specifically a session with you when you went through the because I'd actually made a list of the dangers that were, watch out for these if you're whatever. And you went through each of them and explained why my
Yeah.
In my case, that wasn't really an issue, and wine, went through it all. Yeah. But while there were other options, I still preferred to go for other options until I couldn't. Till that was the only option.
But it worked quite well.
And it worked brilliantly. Yes.
And that's really interesting. So I think you're a very eloquent, very educated person. So you were able to do that. And I wonder now whether for some people who are less able to articulate their anxieties, that perhaps that it comes across sometimes as being difficult. So for some patients might, to a doctor, feel like they're behaving in a difficult manner because they can't quite express to you that they're scared about this treatment.
Yeah. Yeah, it brought to mind, I had a funny incident early on in my teaching career where I was telling the doctor about it, and and he didn't seem to be too worried about it, and I realised I was sort of doing this, and I started doing it more.
Yeah.
And he said, "You're anxious about it." It's sort of,
I think it's interesting, and I think you bring up that sort of giving time or a pause, and I think that is quite critical. And I think certainly as clinicians, I think everything's getting busier, we're having more patients, less capacity, and I think that's very frustrating actually for all of us. I think that you do need to have that time, and I think because it's mostly an outpatient consultation, in lots of ways you have less time as well. Whereas if you're inpatients and in bed, you have more time to be able to talk to people. So I think that's something it's important for clinicians not to forget.
The clinic's a weird sort of situation because it's wait,
Yeah.
busy, wait.
Yeah, completely.
Yeah, and then it's over.
Yeah.
2 hours later.
Yeah, and there's a loss of waiting as well, isn't there? And I guess how could that be held? And so we have a...
When I was coming really regularly, like more than 2 or 3 times a week or weekly, I got to know some of the other patients more, which was really nice.
Okay.
Yeah, and some I'd see regularly, and we'd sort of trade sort of symptoms and treatments and just how it was affecting us and things like that. So that time could be quite useful. It happens less now because I go so infrequently. I don't know anybody in the waiting room. Yeah.
And I think that's something we did used to do before COVID, have sort of patient days and things, but we've not been able to do that. But that's a good point. So, and is that important to you, getting to know other patients?
Yes, I think so. Yeah, and just that sharing of that. Yeah. Particularly because it's a rare illness and a lot of people don't really understand how it works or what the sort of problems for you might be, where another person who's got it might.
And did having nurse support help?
Yes. When you've got issues with getting medication or changing appointment times or things like that, the more contacts you can actually go through to actually find somebody to deal with is really helpful, because that can be quite a headache.
Yes, for all of us. Did it help with sort of the shared decision making as well? I mean, I think for you, I feel like you're probably good enough to be able to look at the internet, and you were very eloquent and interacted well with clinicians. But if the doctors are a bit more scary or a bit more detached, do you think that the nursing side could
Yes,
be
it
more
could
important?
well be. Yeah, it could well be. Yeah.
And you spent some time in the daycare as well, didn't you? So getting the rituximab and things. How did that feel, having the rituximab and being on the daycare and the infusion and things?
Yeah, that was always, there's always a doctor on hand there, which is useful as well whenever I have to go in. And because with romiplastin, you're doing injections, so you've got build-up of sharps that you have to dispose of.
Yeah.
So every now and then I have to find somebody to sort of, so that was always, just standing there sort of hopefully, will somebody take this and get rid of it for me, please.
And is the kind of, at the clinic environment, the phlebotomy service, is that all quite an important part of your experience as well?
Yes. And it's perversely, when people recognised me and knew me when you walk in. They don't have to ask who you are because you go there so frequently. Even the receptionist sort of, sort of thing. That's quite comforting.
Yeah, and it's not necessarily things that hospitals think about, I think. And you had ITP during COVID. How did that affect things? How did that affect your access to hospitals or your kind of?
It was scary going into. At one stage, quite early on in the lockdown, I had to go in to collect a prescription. And it was just, the thought that you were going into the place you probably didn't want to go into, because that's where all the people with COVID were. And some of it was arranged well, but some of it wasn't. So you're sort of, and a bit like the shops. I live quite near a large shopping centre, and when they started to allow people in again, there was strict guidance as to where you should go and what side. But there was nobody enforcing it. So everybody was just ignoring, a lot of people were ignoring it, and that was stressful.
The same in hospitals. Yeah. And how did you feel about sort of vaccines? Do you feel that was discussed well enough with you about having the COVID vaccines, the impact of that?
It was a no. It wasn't a problem for me, I thought that there was something that was helpful. I got them as soon as it was possible to have them. It never occurred to me to sort of worry about it. Yeah. So it wasn't, but I can imagine that there would be people that were sort of anxious about things. So,
Glenys, one of the things that I was quite struck with talking to you about before was the impact that the ITP had on you, just generally. And could you explain that a bit to us?
Well, it's like a major shock. So what was my normal life stopped. Literally stopped. Because the treatment I was on, I was immune suppressed. It meant I stopped a lot of my social life and a lot of the I used to go to the cinema a lot and theatre and sort of meet colleagues I'd worked with and groups of friends, and I sort of limited that, kept it quite. And I'd volunteered I'm doing some volunteer teaching in nursery, and there was no way I could carry on doing that, so that stopped. So a lot of the things that are important in my life stopped, and going on holiday. I cancelled that holiday. That was a holiday abroad. And I sort of got dependent on hospital, I think. I lived near the hospital and just a short walk away. Yeah. And I just didn't, I had to admit myself a couple of times because things went a bit pear-shaped. And that just confirmed it. I just didn't want to do anything that took me away from the hospital, where the people knew me and they could look after me if things went wrong again. Yeah.
And that's interesting, because I think a few things. Actually, the immunosuppression you're on is not that bad. And so I think we didn't explain that well enough to you, I think. So that shows you how important those interactions are, as well. As soon as we tell you immunosuppression, you've then read about that.
No people near me.
And you're really concerned, whereas we obviously didn't do a good enough job of explaining to you actually that you can keep doing all those things. And I remember being struck by the holidays. I hadn't realised that you had stopped going on holiday. And again, I think that just came out of one of our conversations, that it's surprising to me. And the meeting that we had earlier on this year, where again you talked about how your world sort of shrunk because of the ITP.
That was all in my mind, the front of my mind, ITP and sort of other, how does that relate to me having ITP? How does it,
How do you think we could have perhaps done that better? Is there something else we could have done to help you through that journey?
I think early on, there'd been discussion groups with people who were also sort of dealing with it, because different ways of coping with things.
Yeah.
Oh, you know, so can sort of give you a broader field of things.
Well, that's interesting, and we certainly noticed that in one of the paediatric groups that we did, is that parents who are 5 years on can help the parents at 1 year in a way that actually we don't help. So it doesn't matter how many times we try to explain that you're okay. I think that that's a very important point. It's that other patients are better able to explain to you somehow that it's all going to be okay. And that's interesting. That trust isn't quite there when you're brand new to a hospital environment.
Yeah. But also, it's somebody with the similar experiences to you. They're actually going through the day-to-day stuff that you're going through, and they're finding other solutions.
Yeah, so that part of it is really critical, isn't it? And something I think that we haven't progressed in, really, partly due to COVID. And then most recently, you've stopped treatment.
Yes.
And how did you feel part of that process? Did we engage with you enough about coming off treatment and things?
On the whole, there was a little bit of confusion, and I had a couple of phone calls about changing my medications, and I thought, well, why? Everything's okay now, you know. My platelet counts are approaching, you know, normal. They're near enough to normal not to worry about. Why change anything? It seems, and I think I hadn't clearly understood how long the medication worked for within the month. Within the time I was taking it, and the sort of fall off or whatever. So a lot of the counts that I was, you know, were just my system working better. And once I'd sort of realised that, it all made sense. But at the time, I hadn't realised. So I thought I was going to have chemo again. That was what people were thinking, to sort of
the rituximab again.
To kickstart the whole thing and get it, because it still wobbled a bit. My count still wobbled a bit. It wasn't always sort of steady. So it was a relief when I thought, well, no, that wasn't what we were thinking. We were thinking to take you off medication completely and see if your system's reset sufficiently to.
And I guess that was during phone call consultations as well. How did you find the phone call consultations?
Confusing.
I hated them. I really hated them. As a doctor, I hated them. I think it was very difficult to, you know, you're explaining now that you felt quite stressed about being told to reduce it. And on the phone, I think that's really hard to know. Whereas actually, if you're in a room with someone and you know that person well, you can see. Or you would have perhaps got the chance to speak to Dina or one of the nurses to say, actually, I'm really not happy about this. But actually, one phone call and then it's gone. I think that was a very difficult time, I think, wasn't it? And how do you feel now about the ITP?
Well, initially, having not, you know, stopping medication, you're sort of just waiting for something, you know. You're back. It's that thing with your concern for your illness moving backwards and forwards in your mind, the sort of thing. It's back to sort of being a dominant part for a while. But everything was fine. So I'm back to forgetting all about it.
Good. I'm very glad. I think it's one of the many things about ITP which I think is difficult is the uncertainty. Because I can't say you will respond to this treatment, you will need this treatment for this long. But I think that's what's quite difficult around shared decision making as well, as there's so much uncertainty in ITP itself. And I wonder whether that creates a lot of stress and anxiety for patients too, perhaps thinking that we don't know what we're talking about or something. Did you ever feel like that perhaps people don't?
I didn't, because it was unknown origin was part of the title for ITP when I started, wasn't it? Idiopathic. But I remember talking with one of these people I linked up with in the waiting room, who said they don't even know what caused it. You know, how can you? And I said, you don't. I'm trying to explain to her that nobody knows. It's because it wasn't researched enough, sort of thing.
And that's really, I think that's a good point actually, because I think for clinicians, sometimes patients can become quite aggressive.
Yeah.
Because they think you don't know what you're talking about. And I think, you know, I guess my recommendation on that is that for clinicians, we have to hold that and, you know, be honest with the fact that we don't know lots of different things, but all we can do is talk through the things that we do understand. But I think it can be quite scary for people. And is there anything else you would recommend for patients or for doctors about how to manage people with ITP?
One thing I found difficult was keeping track, because we tried lots of different treatments, some in combination. But whenever I saw my GP or I had eye troubles at the eye specialists and things like that, they'd ask you to sort of ask for your past history. So trying to keep up, you know, trying to keep up to date with it and pass it on, and what I've been, you know, when I stopped taking this and when I started taking, and how long I've been on what sort of, having all that information to hand. I mean, I take notes, so, but I think for people who don't, that might be nice if somehow that information is to hand for them when they suddenly need to find it.
And do you use Patient Knows Best?
Yes, I do. Yeah.
Do you find that helpful?
That is, but it took me a while to learn to use it properly. Well, I don't know, I do use it properly, but use it to what my needs are at the moment. Yeah.
And just to explain, so Patient Knows Best, you get the information on your phone, don't you, through your NHS app. So you get your blood test, you get the letters and things like that, don't you, as well? And certainly I would very much recommend that to people in the UK, that's really important. Anything else that you'd like to discuss or comment on?
I was thinking about what the shared decision making, what I remember of it through us, and what it did initially when you were given sort of choices about things or told sort of possible options of ways of handling things. It enabled and it empowered at the same time, because you'd go back and look things up, and then you'd feel better because you understood how things work. So I think that was. I really wanted to say that, because I think that was really important, particularly in the early stages.
And I think that's a really important lesson. That I think that if people are uncertain about shared decision making, it's perhaps thinking that nobody will understand it well enough. One of the other things we developed in our clinic was the ITP patient information sheet with all of the megakaryocytes like platelets, T cells, B cells. Was that helpful?
Yes, I got that from the platelet group as well.
Yes.
And all that is really helpful.
And I think it's interesting because I think that understanding the pathology, I think, is really important for someone. And not everybody will be able to fully understand it, but I think it's there in that visual way. I think that then helps you to understand. And certainly I've just found that in some of the people who've been referred on to me after a few years have been refractory to lots of treatments, that actually knowing why there are treatment options and why they're working in different ways and why some things might work for you, but they might not work for you. Do you think that's helpful to sort of see that there's the different pathways?
Yes, I really enjoyed it. I've stopped going to them because I feel I don't need them now, but the conferences that used to be set up where lots of professionals come and talk in different sort of formats and about different areas of the research and the knowledges, and I really, really enjoyed those. And partly it's meeting other people. It's all about ITP, it's really good.
We have another one on the 6th of October. We're finally getting a new one, so we will set those up again. Okay, thank you so much, Glenys. Thank you for coming and taking your time up to discuss these.
Okay.
And I hope that you found that helpful to hear about that process from us.
Okay.
That was really interesting. Thank you very much, Nikki and Glenys. It's good to hear the perspective from both a healthcare professional and a patient. Excellent. Just want to add one bit before we move on to the next topic. You can add questions in the Q&A button down the bottom of your screen. If you've got any questions that you would like to put to Nikki Cooper and myself, please do. I'm glad, like I know you enjoyed chatting to Glynis about this important topic. Now, following this, we thought it'd be a good time to go through a couple of live polls with you to gauge how often shared decision making is used by yourselves in your ITP patient care and any barriers that may exist with this currently. So to kick off, we have our first poll. How often do you use shared decision-making principles in ITP patient care? So if you just want to click the ones that you use, the results. So always 21%, most of the time 46%, sometimes 21%, rarely 8%, and never 4%, which is very disappointing. But you know, given how far we've come in the last sort of 10, 15 years, and particularly the last 4 or 5 years with shared decision making, I actually find the results quite encouraging, to be perfectly honest. There is lots of information out there about shared decision making. Just before I ask Nikki for her views on this, for all the people watching this webinar who are in different countries around the world, there is a really good website called globalitp.org that has links to all the ITP support associations in the various countries around the world. I think at the last count we had well over 30 associations registered with us. There's links on there straight through to each association's website, and each one has loads of different resources available. So that is good. In addition, we have in the UK the shared decision making document, Making the Right Choices in ITP Patient Management and Care, which many hospitals in the UK have actually picked up. And again, that is on our website. Plus we have the ITP discussion guide, which patients can complete, and it guides them through what questions to ask when they have their consultation with their clinician. Those are available on itpsupport.org.uk. Nikki, have you got any other bits about resources available?
Yeah, no, I think we use both of those. I think the shared decision-making document is great, really good. And I think it's really helpful for patients to have something in their hand to take away. So that's been really helpful for us. Absolutely. I think, and it's, you know, you can see that from kind of Glynis's comments, is that actually patients do go and Google, they're going to look up things. So I think we do need more information sheets that we can actually give to people. I think that does make a difference, and it's been great for us. So yeah, thank you for spearheading that. That's been really good.
Okay. Right, moving on to the next poll. If it can come up on the screen, right. What are the key barriers to implementing shared decision making in your clinical practice? Please select all that apply here. I suspect time and resource are going to be way up there. Nikki's shaking her head, agreeing.
Yeah. I think that's the thing, isn't it? I think the time is the big issue, and it's getting worse and worse. And I think,
especially now with all the pressures on the systems.
I think the other thing I think I've noticed as well is that sometimes it just takes a few consultations sometimes to get a better rapport with people, so you can actually start to understand each other. So that's important.
Yeah, talking to, you know, lots of patients as well, like, you know, that they say something similar, it takes them a while to actually get to know the consultant and get the confidence to actually be able to ask the right questions. So
totally. I thought something Glynis said which was really helpful was that pause, isn't it? Giving, not always talking and filling silences, giving the time to say things.
Because some of the information that is being shared, you know, can be quite detailed and quite daunting really for a patient. So one
of the other things I think I've learned as well is that it's okay to say I don't know. So I think, you know, and I think that's important for patients, that if you say I don't know the answer to that, and also to say, I don't know, but I can ask someone else, or actually nobody knows. And actually that's, you know, it's important to say that sometimes, I think.
Yeah, I think we're probably coming to the end of this question. So let's have a look at the results. Time, way, as we said at the start, 75% of people think time is one of the key ones. Resources, that can be not just paper resources, but information resources and staff resources as well, within the clinician environment. So 36%. Patient health literacy, what we were just talking about, you know, do they have the confidence to actually ask the right questions? Lack of training, this has come up a few times with, and you know, you can't blame GPs, but most GPs will only ever see 1 or 2 people present themselves with ITP in surgery in you know, during their career. So that is a key.
I wonder whether that also means lack of training of how to deal with shared decision making as well.
Yes, it probably does. It probably does, because shared decision making, as we've said, is relatively new as far as, you know, coming from the NICE guidelines and the ASH guidelines. But yeah.
And I think kind of chronic diseases is very different from acute diseases. So actually within haematology training, a lot of it's spent on acute admissions, leukemia patients on the wards, and that's a very different place from outpatients. And I think that the registrars don't get enough training in outpatients, actually. Actually working out how you manage people on a long-term basis. This isn't someone you're just seeing while they're in the wards. There's lots of other resources, there's lots of nurses there as well. Outpatients is a really different place, and I think we're probably not so good at training. Actually, we don't have the, you know, we're not spending lots of time.
And the last point on there, lack of guidelines. Now I know the guidelines are out, like, you know, maybe it's guidelines in the, you know, environment of each individual hospital. I'm not quite sure on that one. So if anyone's got any points I'd like to add, put them in the Q&A.
I think the other thing is, as well, is because we know how heterogeneous ITP is as well, isn't it? So when we write guidelines, the way guidelines are designed, it's to suggest that it's all one disease, or hypertension or cardiology, and it's really isn't, is it?
No.
And we know that from the research we do as well, it is not one disease. So that's why guidelines become quite difficult, I think, to be personalized, I think.
Okay, that's that one. Right, let's go on to the next one, the next polling question. I think it's the last one when it comes up. Right, what would you like to improve your skills in shared decision making? Would you like to improve your skills in shared decision making?
Resounding yes.
Yeah. Well, we know this is going to be 100%. So yeah. I'm not surprised at all.
Maybe we should do some training sessions, Mervyn. Maybe that's it, you know, thinking, you know, but seriously, sort of for junior doctors or junior consultants in you know, beginning on that journey of how to become a good doctor, and actually just having some kind of role play kind of sessions.
Good idea. We should put that forward, I think. So Okay. Thank you, everyone, for taking part in the polls. Right, so to finish today, this is the Q&A session now, Nikki. So to finish today, like in finishing our webinar, we're going to go into answer a few of your questions, which have come in during the session. Thanks to everyone who submitted a question for us today. If you haven't yet, there is still time. We would do our best to answer as many as we can. So, Nikki, you want to do the first question?
Yeah, sure. So first is a question for you, dear Mervyn. Thank you for your contribution. Having heard many experiences from the patient community, what's the main fear that patients have when entering the physician's studio and preparing them to speak for the next steps? Does that prevent them from speaking freely?
Oh, God. Talking to people with ITP, lots and lots of them say when they're first told that they have the condition, it is absolute fear. They fear the worst. It's a complete unknown of what lies ahead, changes to their lifestyle. what the treatment options are, and we know the treatment options are numerous now thanks to advances in recent years. So it's you know, a complete unknown, but what I've found is very quickly ITP patients quickly become very knowledgeable about the subject. And that's down to people like yourself, Nikki, and other people around the country in similar positions, you know, imparting the knowledge onto the patient, which is needed.
Interesting. And I guess you're also getting the people who are looking outside, aren't you? You're getting people who are self-motivated to try and find some information. Okay, so the next question is for Glynis, but she's not here with us. Next question is for me. Thank you for your help and commitment of making patient lives better. Should you have one single golden recommendation to your peers when it comes to listening to patients, what would it be? I think it's giving people space actually to talk and having an open countenance so you can actually say, listen, and actually what sort of Glenna said, giving people space and not speaking the whole time. So
yeah, they need the space and that take it all in, decompress from what they're being told, etc. and all that. Yeah. Right, there's another question. Shall I?
Go. Yeah.
This one is funny enough, something very similar to what we was talking about at your ITP day. What are the different types of patients and how do you respond to them?
That's a great question. I think they are there are psychologically different patients as well as treatment responsive different patients, and I think that's the thing, the art of being a doctor, is working out what kind of persons you're talking to. I think alleviating people's fear, trying to explain things is really crucial. Trying to get people's trust is really important. Then regarding the different types of ITPs, we don't have the biomarkers for that yet, actually, and that's something we're trying to work towards, trying to work out what kind of treatment people respond to. And actually only time tells, really. I think one of the things I've learned about managing patients is actually just saying that we don't know which treatment you're going to respond to. We don't know what the response is, but we will get there. And so it's sort of managing expectations of the fact that there's so much we don't understand about ITP, but that we are trying.
Okay, another question. Do you have any advice for healthcare professionals looking to implement shared decision making more often?
I think don't be scared about it, actually, and actually recognizing that, as you say, a lot of patients with ITP are very they're well educated, but they may not know or understand nuances. So I think some of the things I've discovered from patients is they get very scared. Like you saw with Glennis, she was terrified that she was going to die after rituximab, or some people have been terrified about black boxes on L-trombopag, that you might get liver failure. So recognizing that that's what people are going to do is go and read things and trying to put that in context. So I think that's what we need to do for patients, is put things into context, because I think people are very scared about small things that they're reading, and trying to understand that fear as well. So not feeling threatened as a doctor because the patient's challenging you, and realizing that a lot of their sometimes negative attitudes comes from fear themselves, and remembering that they're a patient actually with a disease that can be quite frightening too.
Okay, thanks for that, Nikki. That's all the questions we have had time for today. There are a few others, but we will try and answer them, and when we publish the video we will put answers to them respective questions. Thank you so much to Dr. Nicola Cooper, or should I say Professor Nicola Cooper, and Glynis as well, for taking the time to share their knowledge and experience with us. And of course to everyone out there in the land of the internet for joining us today and taking the time to participate. We hope you found the webinar useful. We'll be sharing the recording of the webinar afterwards, so you can revisit this at any time. Thank you so much for taking part. Good evening all. Thank you.
Thank you.